lot of the Canadian literature, or some of the Canadian ER literature is looking at early rhythm control and not rate control. That's their aggressive AFib correction management of onset of less than 48 hours. Kind of like we point out, it's really hard to time that 48 hours. The symptoms could have been actually there without symptomatology noticed by the patient. That's obviously getting into a gray area of what is truly 48 hours. But in your opinion, should emergency physicians be more aggressive at obtaining this rhythm control as the priority over rate control?
For ED particularly, and I'll take that, there are 3 scenarios that I can think where you could use it. One, I think there's no doubt, if the patient is hemodynamically unstable, you do a cardioversion. Number 2 is, if he's a young guy with no risk factors, the so-called lone atrial fibrillation, if he comes in and has specific timing, that it started at 7 p.m. and it's hurting, and again, there is no literature yet. People are looking into different things, some from pacemaker diagnostics and other things. But I would say feel safe if it's less than 24. I start getting uncomfortable in the 24 to 48 hour range. We have old data but no new data. And we know that strokes still do happen, even beyond 5 hours of atrial fibrillation onset. So no risk factors, less than 24 hours. Yes, I would feel safe to cardiovert them in the ER. Now that could be done pharmacologically or it could be done electrically. Mm-hmm. And then, they could be sent home because they have no other issues going on. They'll feel fine. The third issue is, or the third scenario is somebody who is known to have atrial fibrillation and has been on anticoagulation. And when I say atrial fibrillation, meaning paroxysmal, starting and stopping on its own, not somebody who's been cardioverted multiple times in the past.
Or flecainide, like pill in the pocket?
Right. So yeah, that's a pharmacological thing. So coming back to that is, so if somebody has been on anticoagulation already because they have a diagnosis of atrial fibrillation, and they come in with clear-cut symptoms, and that's their only symptoms, you could do a pharmacological, and one of those things could be flecainide, or electrical cardioversion and send them home. So emergencies, young patients with no risk within 24 hours, or somebody who has been on anticoagulation for AFib, you could do those in those 3 scenarios.
Has or is?
Has a prior history, so has been on Coumadin. The idea being, when we do these electively also, electrical cardioversions, you want them to be on Coumadin at least for 4 weeks before we do it. And again, these are old data to say that if you've been on it, the risk of thromboembolic complications after stroke is low. So if they've already been on Coumadin, and when they come in, their INR is therapeutic, that's another key thing. Gotcha. They may have been on Coumadin, but if their INR is 1.4, then it's a moot point.
So we have our patient now, and we find out, let's say we change this now, and our patient is actually known to have this history of AFib. Is not on Coumadin now, but so we need to start anticoagulation, and we're going to advise that she stay in the hospital or go home.
So. Is that okay? I'll take that. So again, if this is a patient, 43-year-old, which has no other risk factors.
Yeah, we'll keep it simple.
And to keep it simple, you said has a history of AFib. Mm-hmm. But I'm presuming if the patient is not on anticoagulation therapy, it doesn't have high risk factors that was not considered to be on anticoagulation therapy. The answer, the CHAT score is low, and we can discuss that later. So, and very particularly, she can state that the onset is within 24 hours or something. You can cardiovert them and send them home.
Well, she's saying 2 days.
Well, if it is 2 days, then you have to do a transesophageal echo. The reason behind that is long-term anticoagulation is decided based on what your CHAD scoring and other risk factors are. But anybody, even with a score of 0, who is cardioverted, pharmacologically or electrically, has to be on anticoagulation for 4 weeks. So that particular person, more than 48 hours, TE, cardioversion, and then anticoagulation. Now, anticoagulation has become simpler now, but I don't know if you're going to discuss that later.
We will, yeah.
Okay.
So does this person need to be hospitalized then? So we have 48 hours. Can I anticoagulate them and send them home to do this all as an outpatient?
Absolutely, yes.
Okay.
Key is provided no other risk factors.
Right, no other risk factors.
Right.
what rate is safe to send home? What rate do I need to get this woman under? Is 100 safe to send home? 120 if she's comfortable, hemodynamically stable?
The key word is comfortable. So when we look at rate control and rhythm control approaches, it is the symptom that changes somebody from a rate control approach to rhythm control, besides other things. But when we are, especially in the ED, we want them to be controlled in the rhythm or cardioverted or converted. It is the symptom. So you've controlled the rate, yet the patient is having symptoms, then you go to the next step. But however, let's say the patient, you've controlled the rate and it's fair, and he's like, I feel okay. Anticoagulation, send home, elective cardioversion if he doesn't spontaneously convert in 4 weeks is a reasonable option. To answer the question, what is a good heart rate control? Well, the patient would be resting. So the data, in the ED is, if they have no symptoms, even a heart rate less than 110 is okay. Previously, we used to think you need an 85 heart rate, but there's some data from RACE2 trial which said even 110 or less is okay.
So now we get into the option, we'll make her 24 hours, and we're getting the choice of simple patient, no risk factors. We're going to try to cardiovert her. Do you think that, is there any good data that says, electricity is just as safe and we can just zap them, get them in, get them out? Or should we be using flecainide? Should we be using Avula2? Should we be using procainamide? These other more aggressive pharmacological measures that you guys tend to use a little bit more comfortably than we do. What would be your recommendation for that rhythm controls right there, right then and there?
So for electrical cardioversion, the advantages are it is more effective. It's almost, if not 195% effective. The downside is you need conscious sedation, which is not needed with pharmacological conversions, thermal injury and things like that. The thing with pharmacological conversions is the sooner you get them, the more effective. So if you're beyond 24 hours, the likelihood of conversion is low. The best possible converter right now is ibutylide. There's some new coming on the market, but ibutylide works better for flutter than for fibrillation. And the success for fib is about 60% or so. And if it's going beyond 24, 48 hours, it keeps coming down. So I think it is worth, if he's in the ER kind of situation, it's worth trying a pharmacological conversion. If he doesn't convert, you can do the cardioversion. The one place where I would use a pharmacological agent before doing electrical cardioversion is if the patient has been in AFib for a longer duration or has had frequent episodes. Because one thing that you will sometimes or often see is you cardiovert them and they go back into AFib. That's not a failure of cardioversion. It's what we call immediate recurrence of atrial fibrillation. And when you have initiated an antiarrhythmic drug before, it helps in maintenance of sinus rhythm, whether it is ibutylide or flecainide or one of the other agents.
I think we'll put it in the show notes for later. We'll go over digoxin magnesium just for the sake of time. We'll move on to anticoagulation. You've been talking a lot about the CHADS score, the CHADS-2, and then some of the newer literature that I've been reading is actually pointing to the CHADS-2 being less effective than CHADS-2 VASC should be what we're using. Is this truly a externally validated, this should be the standard score that we use to risk stratify our patients for anticoagulation?
So I think we should start with CHADS-2 score. Where CHADS-2 VASC comes, and I'm sure everybody's familiar with CHADS-2 scoring, C for congestive heart failure, H for hypertension, H 75 greater, D diabetes, and S2 means stroke gets 2 points. So if you add these together, and if you have less than 1, meaning 0, then you don't need anticoagulation. Aspirin is okay. If you look at European Society, they say even aspirin is not needed. If it is more than 2, aspirin doesn't work. Aspirin Plavix doesn't work. The only thing that works is Coumadin, and now we talk about other agents like dabigatran. So if it's greater than 2, no doubt, heparin, Coumadin, or whatever. Less than 1, nothing or aspirin. It's the one that we are stuck with, because the guidelines say you could do aspirin or you could do Coumadin. If you talk to many of the EP guys, we all do Coumadin or Pradaxa. If you talk to the internal medicine guys, they'll do aspirin because it's less nuisance. So it looks at our comfort when we initiate it. So what the CHADS-2 VASC has really done is it tells to use the CHADS2 VASC is only if you have a score of 1. So if you have a score of 1 and adding the CHADS2 VASC increases your score beyond 1, then go the Coumadin or the other anticoagulation route. However, if your CHADS2 risk score remains 1 despite the CHADS2 VASC system, then you can stick with the aspirin route.
So I've got our 48-hour, let's call her. She converted in the ER spontaneously. Does she need to go home on anticoagulation?
Well, if it is within 48 hours, and again, we have to base it on scientific data, and she has a score of 0, the answer is no. You can put it on aspirin and send her home. Beyond 48 hours, then for at least a month.
So regardless of sinus or maintains. So, and is that because of that atrial stunning idea?
Yeah, in fact, I'll take this back. Only if we have cardioverted or pharmacologically converted it. But if they spontaneously convert even in 48 hours, but they did it on their own, then aspirin is okay, because then we are dealing with the so-called paroxysmal AFib with a score of 0. So then they don't. But it is the conversion part that is thought to be more thrombogenic.
Okay.
And that's why you need anticoagulation at least for 4 weeks.
So we give her, she's 48 hours, we convert her using some either chemical or electricity. She has a CHADS score of 1 or greater, or CHADS VASC?
Doesn't matter if you've converted her.
So long as it's not 0, she needs to be on some form of anticoagulation?
In fact, even if it is 0, for 4 weeks, she needs to be on some kind of anticoagulation.
Because we use some sort of chemical, right, or we use an electricity?
So beyond 4 weeks, if the CHADS score is 0, you can stop it.
Okay.
And if it is above, then you continue indefinitely.